speaker who will talk on extravasation management is the clinical pharmacy team leader of the Department of Pharmacy Services of Makati Medical Center. He is also the antimicrobial stewardship clinical pharmacist of the same institution. He graduated his Bachelor of Science in Pharmacy at the Central Scholar University School of Pharmacy. And today, again, to discuss extravasation management, let us all welcome Mr. J. Christian Muere.
So hi, good day. My name is J. Christian Duke Muere. I'm a clinical pharmacist, and it is my privilege to share with everyone the topic on extravasation management. So to begin with, we all know that infiltration and extravasation are two well-known distinct complications of intravenous therapy. But what is the difference between the two? So the difference is that the solution involved. When it is a non-vesicant solution or medication, we call it infiltration. When the solution is a vesicant medication or an irritant medication or solution, then we will call the incident as extravasation. But literally the two are just the same. It only differs on the solution involved. So here is a process by which extravasation can happen. So there can be a total displacement or a partial displacement of the IV cannula tip into the adjacent tissue, resulting to the leakage of the solution in the surrounding tissue. So the solution can be medication, intravenous fluid, or sometimes a radiocontrast. The incidence of extravasation in adults is estimated to be in range of 0.1% and 6% in patients receiving chemotherapy. This is according to the study of Makara extravasation study. Another 5-week period study was done in the UK hospital, and the result was 39% in adults experienced extravasation. Extravasation is a common occurrence not only here in the Philippines but in other countries. But few studies report the incidence on the basis of firm data. So it is important to report extravasation events in our hospital or in our institution to have a good documentation or good verification of the events. It was also noted that hospital shouldn't be exempt from reporting faulty radioisotope injections. Extravasation from radioisotope injection results to high radiation exposure. So in general, extravasation can happen with medications like amiodarone, like propofol. It can also happen using parenteral nutrition. But again, extravasation can happen with radioisotopes or radiocontrast. The only difference is that with radiocontrast, it exposes the patient into a high level of radiation. So for the consequences, skin necrosis, skin contractures, subcutaneous damage, tissue damage, nerve damage, ischemic necrosis, and sometimes amputation of the affected limbs or area are the result of extravasation events. So here are some examples or pictures of the damages. Unrecognized extravasation remain the cause of serious liability per clinician with lawsuit for mismanaged. So in the US and in other countries, there are many law firms that assist patients who are victims of malpractices, victims of extravasation events. So patient can claim or can file complaint regarding the damage that had been done to them. So it is important for us to know the causes of extravasation. It can be medical causes, patient-related, or work-related causes. So what are the different causes of extravasation? It can be due to drugs or fluids. It can be caused by damage when the IV tubing was placed. So proper administration of intravenous to the patient is very important. Or a very careful nursing technique in IV administration is very important. It should come out of the vein if it's not secured properly. So management and monitoring of IV inserted material should be properly managed and monitored. So we have patients at the ICU with multiple high-risk materials that are possible for extravasation So we should have a list of these medication or solution that are possible or high risk for extravasation. So we should have a policy or a reference of all these materials. Recognition of high-risk patients is very important. Appropriate cannulation technique by the nurse is also important. Monitoring of high-risk materials should be standard of care of precaution, but still extravasation does happen. So knowing the signs is very important. So what are the different signs that we need to watch out? So this includes changes in color, like redness around the site, or lighter skin around the IV site. Another sign is that change in temperature around the IV site, where the scalp, hand, arm, leg, or foot near the site of IV insertion. An IV not working can be a sign of infiltration. And also pain, tenderness around the site, including redness, swelling around the site is also a sign of extravasation. So the nurses should monitor their patient and check for the following, as noted in the slides. So I included this slide since most of the medication to manage the cases presented here are of high risk for extravasation. Example, we have this management for the traumatic brain injury. So we use mannitol. So mannitol is one of the solution that can cause extravasation. We have antimicrobial agents or antiviral drugs that must be diluted and infused using a proper technique, proper solution. Because if those antimicrobials are not dissolved properly or infused properly, these materials will cause extravasation. For the management of ARDS or respiratory distress syndrome, we are using multiple vasopressors. We're also using anesthesia agents that are of high pH, of high osmolarity that can cause tissue and also vein damage. So we need to have a list of all the materials, medication, and solution that are possible for extravasation. So I included here list of different solution medication that can cause extravasation. First on the list are the pH-based list. So we have here medication or solution with high pH, very high pH, and very low pH. So infiltration of these agents with non-physiologic pH may cause or predispose patient to severe form of extravasation injury. Next on the list are the medication or solution with high osmolarity base. So we have here glucose, 10%, 20%, or as high as 50%. We have electrolytes, we have antibiotics, and we have also sedatives. This medication with high osmolarity level can cause osmotic stress that can lead to cellular transport dysfunction. It can also lead to cell volume dysregulation and direct protein or DNA damage. I included in the list the different Vesicant anti-neoplastic agents, also the different Irritant anti-neoplastic agents. So for the next slides, I will be sharing with you our institution different practices and innovation that we did to prevent extravasation, not only for the prevention, but also for the management of extravasation. The first and very important thing that we must have is that we need to have a plan or a policy on how to monitor and to manage extravasation. So what we did is that we created a list of all the caustic agents and the management of the following agents under the medication management use policy of our hospital. To prevent error and to promote identification, we created different stickers. So these stickers include avoid extravasation sticker for medication that can cause extravasation for proper precaution. We also have this IV drip sticker. Another sticker is this must be diluted first sticker with a single use only and discard remaining solution sticker. So we have these stickers to prevent error and also to promote identification. Another sticker is this auxiliary sticker to be used for hazardous drugs. Another innovation or a way to promote safety is that we created a reference under the pharmacy department, which is about the management of drug extravasation. Included in this reference are the following: the list of anti-neoplastic agents that can cause local toxicity. We have here a list of vesicants, irritants, and non-vesicants anti-neoplastic agents. We also have a list of non-anti-neoplastic agents that can act as a vesicant or irritant. Example of vesicant non-anti-neoplastic agents are mannitol, amino acid with high concentration. We also have concentrated electrolyte and parenteral nutrition with high osmolarity level. Radiographic contrast media is also included in the vesicant non-anti-neoplastic agents. Included in our reference are also the prepared antidote for each extravasated medication. Example, we have this hyaluronidase as the prepared antidote for aminophylline. Another technique or way to manage or prevent extravasation is that your institution must have a updated drug dilution table. So here is a drug dilution reference or dilution table in our institution that does contain the following. We have the drug, the run rate recommendation, the maximum concentration, if it can be given as IV drip only or as an IV push. So an example here is calcium gluconate, can be given as push, but the recommended rate is included in the list. If it will be given via drip, the recommended concentration, including the running rate, is also included in the list. The maximum dose per day is also included, including the compatible solution. Another policy that we created is on how to give concentrated electrolytes. It includes the total volume, the total dose per day, the total maximum running rate per hour, and the important information that are needed by the nurses on how to give these electrolytes. We included in our formulary the drugs that can cause extravasation, including the antidote. An updated and available reliable reference is very important. So as you can see here, this reference was updated last May 7th. So this one is very updated. One possible improvement or possible improvements that we can apply in our institution is that we can create an extravasation kit and also an extravasation event flow chart. So we will know how to manage on step-by-step level every time we have a extravasation event. So it is important that we have a process, a policy, and list of all the things that we need to have and things that we should know. The primary approach to injury of extravasation includes combination of 1. Non-pharmacologic, 2. Reversal agents, and 3. Sometimes surgical intervention. But for the initial management of extravasation event, these are the following recommendations. It is recommended to stop the infusion immediately and check for the different signs of injury. Next management recommendation is that it is not recommended to remove immediately the catheter or the needle. Aspiration of the fluid is very important. Flushing of line is not recommended. If needed, you can remove the catheter or the needle. Elevation of the affected limbs can help stop the further spreading of the solution. Compresses using warm or cold can help alleviate the pain or even stop the spreading. It should be included in the management the monitoring and the documentation of the event for proper investigation and proper improvement or further improvement of the system. So I included here some extravasated medication or medication that can cause extravasation and recommended uh, antidotes. So we have here aminophylline. Aminophylline, the prepared antidote is hyaluronidase. So hyaluronidase is injected intradermal or subcutaneously. As shown here, we have the recommended doses, the recommended technique. So for the supportive management, if we don't have a supply of hyaluronidase, we can apply dry cold compresses. For the amino acid with high concentration, including parenteral nutrition with high osmolarity level, the recommended or the preferred antidote is hyaluronidase. The supportive management is application of cold, dry cold compresses. For the amiodarone, the recommended or the preferred antidote is hyaluronidase. It is recommended to inject it intradermal on a 5 separate 0.2 ml injections of 15 units per ml using a 25 gauge needle into the area of the extravasation. Special technique is very important to prevent further damage in the area. So for the supportive management, it is recommended that we can apply dry warm compresses. For the calcium salt, including calcium chloride and calcium gluconate, for the early calcium extravasation, we can use hyaluronidase. For the delayed calcium extravasation, we can use sodium thiosulfate. For the supportive management, apply dry compresses. Apply dry cold compresses rather. So same with calcium gluconate, we have the same antidote with that of calcium chloride. We can also apply dry cold compresses. Since contrast media or radioisotopes can cause extravasation injury, so the prepared antidote, we don't have exact prepared antidote, but some recommends hyaluronidase. For the supportive management, some suggest warm, some suggest dry cold compresses, but both can help. The supportive management depends on the institutional policy. For the dextrose with high concentration, with high concentration from 10 greater than 10% to 50%, the recommended prepared antidote is hyaluronidase. So for the supportive management, we can apply dry cold compresses. There is no known prepared antidote for the diazepam, but for the supportive management, we can apply dry cold compresses. For the digoxin, the supportive management depends on the policy of your institution. For the vasoconstricting agents like dopamine, the prepared antidote is pentolamine. So you can use pentolamine, or sometimes you can use topical nitroglycerin ointment if available. But data on how to use is very limited. For the supportive management, we can apply dry warm compresses. Another vasoconstricting agent to vitamin, the prepared antidote is pentolamine. For the supportive management, you can use apply dry warm compresses. Immannitol of greater than 5% may cause extravasation or even tissue damage. So the prepared antidote is hyaluronidase. For the supportive management, you can apply dry cold compresses. For the phenytoin solution or medication, the prepared antidote is hyaluronidase with the supportive management of applied dry warm compresses. For the potassium salts, like potassium acetate, potassium chloride, potassium phosphates, these are high alert concentrated electrolytes. So we can use the hyaluronidase as the prepared antidote. For the supportive management, we can apply dry cold compresses. For the sodium salts, like sodium bicarbonate, sodium chloride, with high concentration, or concentrated solution. Can apply for both. You can apply hyaluronidase. Supported management, you can apply dry cold compresses. For the total parenteral nutrition with high osmolarity level, so it is recommended to give hyaluronidase for every event of extravasation. For the supportive management, we can apply dry cold compresses. Sometimes it is recommended to use nitroglycerin topical ointment using an inch strip or the site of ischemia. It may be repeated every 8 hours as necessary. So, talking about parenteral nutrition, some parenteral nutrition has a high osmolarity level. So, extravasation concerning vasopressin, the prepared antidote is the application of nitroglycerin topical ointment. Then the supportive management is application of warm compresses. This is based on the mechanism of extravasation injury proximal to the injection site. It is also important that the company or the institution or your hospital should have a complete list of all the chemicals, including chemicals or medication, including their data sheet, so that you will know how to monitor, how to store, and also how to manage events, such events like extravasation. So I have here radioconchas, like primobolis and ansatax. So this is a data sheet that includes how to store, how to manage, and how to monitor. As discussed a while ago, we have different antidotes. So I have right here different antidotes with different pictures available in the market. So we have here dextrososane. It is a derivative of EDTA. It is a chelating agent. Another antidote, we have the MSO or dimethyl sulfoxide. It is used to minimize tissue damage in extravasation concerning anthracycline, mitomycin, and mitoxantrone. So we have here one of the most prepared antidote, which is hyaluronidase. Hyaluronidase increases the diffusion of the extravasated fluids or medication that can result in more rapid absorption, thereby limiting tissue damage. For the vasoconstricting norepinephrine, the antidote is pentolamine. So pentolamine can minimize tissue injury due to extravasation by vasoconstrictors. So how to give? We inject 5 to 10 milligram diluted in 10 to 20 ml normal saline, inject or infiltrate it into the area. The window period is only 12 hours. Maybe administer if patient remains symptomatic rather. Another antidote, we have here topical nitroglycerin or terbutaline. This is alternative to pentolamine. So these antidotes are used for the symptomatic vasoconstrictor cases. Another antidote, we have sodium thiosulfate. This is for the prevention of alkylation and subsequent destruction of cutaneous tissue concerning cystatin, then the mustine extravasation. Another technique or mechanical technique that should be done by a trained person or trained medical person is by using saline washout. So this is a very important technique on how to wash extravasated solution in the tissue. Only a trained person can do this. Another supportive management is by using cold or warm compresses. For the cold compress, the result will be vasoconstriction, then potentially restricting the spread of the drug, thus decreasing the pain and inflammation in the area of extravasation. For the warm compress, it increases the blood flow, thus increasing circulation and facilitate removal of drug in the area. I think this is the last slides, and for my final takeaway, extravasation can be managed and can also be prevented And with that, I would like to thank everyone, including Delex Pharma, for inviting me. Thank you.